Good evening, everyone. This is Dr. Murugan. I am a consultant physician in Lifeline Hospital. I also work in Rajiv Gandhi Government General Hospital. I thank all of you and my Lifeline family, an excellent team, and lots to learn from them, and expand the greatest patient care and experiences. And wonderful time working with my Lifeline Hospital. So, a medical case. We had 25-year-old female who presented to us with dental pain since past 2 weeks. There was history of fever, intermittent in nature, associated with chills and rigors, and that was temporarily relieved with medications. And there was facial pain and swelling. And one thing was that the right side neck swelling was a complaint, and that was for a week. Now, patient developed labor pain. This is a lady from a remote area, a tribal area. They didn't have much medical facility. So she was picked up by the local primary health center or the government hospital people because of the labor pain, and she was transported to a government Vellore Medical College Hospital. And during that transport, she was in a primary health center and she was transported to the Vellore Medical College Hospital. On that early morning of 7th, she delivered within the ambulance. She was rushed and she had a PPH, which was luckily managed conservatively. She had a reasonably healthy baby boy. And this lady with a para 3 with these 3 children was on severe sepsis. I'll show you the picture. And with severe anemia, and this patient was in Vellore Medical College Hospital for 2 days. Now we received her on 10th of Feb, and 3 children married at the age of 17 years. Small negative history, no history of trauma, bite, no known comorbidities, and no history of any allergies, and no bleeding manifestations. Now, she was very irritable, which we can understand, tachypnic dyspneic, and she had grade 3 trismus, very difficult to open her mouth. Pallor, yes. A muddy conjunctiva with pedal edema. There was no obvious cardiac, JVP rise or any cardiac picture abnormalities. With that, she had a pulse of 86, but that was low volume pulse, low volume, and pressure was reasonably okay with a saturation of 98, mild tachypnea, and she had vesicles over the angle of the mouth, and there was severe chemosis, facial puffiness, and uh, distributed lymph nodes, tender lymph nodes over the neck region and the submandibular region. The systemic examination in the respiratory system, she had decreased air entry over the bilateral lower zones associated with Krebs. Okay. And rest of the irritability was there, but the GCS was reasonably okay, 12 out of 15. And this is the lady, this 25-year-old, and she was not willing for any treatment on the day, an hour of admission. She was not willing for treatment. She said, "I want to go back home. I want to see my child." Okay, and that was she was in full sepsis. Now, point of care ultrasound, we had an IVC, we saw an IVC of 1.76. Mild pericardial effusion was present. EF was 50%, and USC abdomen showed a mild hepatosplenomegaly, and there was a bilateral mild pleural effusion. The parotid and neck did show parotid enlargement, as well as there was some centimetric lymph nodes, that is intraparotid lymph nodes. See, this is the picture, the lab reports from the Vellore Medical College. We see clearly that she had sepsis, anemia, and thrombocytopenia. And also there was a azotemia, creatinine levels picking up, and that was pre-renal acute kidney injury, perhaps. And also the bilirubin count was elevated. There was definitely some ischemic changes happening over the hepatic region. Now, what is the problem with this lady? So we have this 25 with severe anemia, thrombocytopenia, facial cellulitis. Can it be mumps? Suspected mumps infection. Sepsis, yes, versus tropical infection, because that was the February time where we did have lots of mixed infections just to confuse us. And then added on a bilateral cervical lymphadenopathy, any immunocompromised state. Immediately we want to be very careful, right? We cannot be with an lower antibiotics. Immediately placed her on Miro. Since there was AKI, we placed on 500 mg TDS, clindamycin, just to make sure we given streptococcus and pneumococcus, staph coverage, anaerobic coverage, in addition to Miro. Doxy, because we suspected, we saw an S curve. We thought it could be some tropical infection. So just to make sure, we added the doxycycline as well and other supportive medication. CT imaging of the facial bone, it did say right parotitis and facial cellulitis, lymph nodes, yes. And a contrast on over the neck did say right sternocleidomastoid muscle. There was abscess collection. Along with that, there is retropharyngeal collection measuring an amount of pus that was extending between the C2, C5 level. Now, also there was a right internal jugular vein thrombosis, and there were the levels of lymph node appreciated, and CT brain was normal. Now, within 2 days, we called all our multidisciplinary team, and surgery, ENT, all the team came, and we could get some ideas as to what it was. We were dealing with. Otherwise, we could easily lose her history wise. Do you think that we could get a proper history from her or her mother? No, it was difficult. So we had to do a math. Now, ENT, we had to get this as this was identified. That is, first we have to drain, like how Monica madam said that, the immediate corrections did definitely help that patient. Same here. So by video laryngoscope with an intubation, patient had this pus drained, and there was about 15 ml of pus drained. That was frank, purulent pus, which was sent for CBNet. We always suspect tuberculosis. That's the first thing we always think about. So we send a CBNet test as well, along with other tests. And also this maxillofacial surgery was called in, right? So they said generalized chronic gingivitis and localized chronic periodontitis, especially over the lower, that is 41 is lower right central incisor, as well as 43 is canine. So definitely there is dental infection also. That's the point. Other investigations, like we suspected, she turned to be a scrub IgM positive. So doxy was helping her, and other tests were normal. We have to be just, autoimmune is always a confusion. So ANA was negative, and APLA, antiphospholipid antigen, was negative. And in our setting, that is day 2, day 3, I took a random days of labs, and we could see that she was recovering lab wise. Still, she had to improve clinically, and her anemia was being corrected reasonably okay compared to the first day, and the thrombocytopenia was recovering, and so were her metabolic parameters as well. The urea, creat, total, bilirubin levels were reasonably okay, and so was the serum albumin. Now here, this is a day 1. There were previous X-rays taken. I didn't want to put too many images. So day 21, she started developing. I still haven't said what exactly this patient is suffering from. So see, we had this patient for 3 weeks. We were thinking of there could be dental infection, sepsis, perhaps she never got corrected, and she didn't get treated, and pregnant mother, pregnancy, again immunocompromised state. But then why is this pleural effusion coming? Are we dealing with tuberculosis? Over the now IJV, right IJV vein, right IJV was thrombosis was there. So at that time we didn't know that that was the syndrome, but then later with the CCT, this could be bilateral bronchopneumonia that could be told, but also since there was right IJV thrombosis, we thought it should be a septic emboli. So there was a right IJV thrombosis, and there was pleural effusion, and there was also a collapse over the left lower lobe. And this was the time when we had to place her on ICU. We had to put a place on intracostal drink. Now, we did pleural fluid for 3 times, 3 different times, and it all showed an exudative pleural effusion. Exudate, and adenosine deaminase was negative, AFB net were negative, but this Acinetobacter was found, for which amikacin we started. I'll tell you what were the antibiotics later we added up with. And also with remember the 15 ml pus that got drained from the right sternocleidomastoid that showed Klebsiella. Now other parameters were normal, and also a tissue analysis was sent just to make sure we are not missing anything, but that didn't much show any significance. And definitely the CRP and ProCal. See, on those the early days, definitely CRP was very high in 200s, and the ProCal was 8, right? And then as she was going through with the treatment, she fairly had a reasonable control of her infection. Antibiotics we used initially, Miro, Clinda, and Doxy is what I told. We added a vancomycin also just to make sure this is not MRSA, although it didn't show a MRSA in the growth culture. Then, as she was getting better, remember the 21st day where you saw pleural effusion, almost moderate pleural effusion. That was the time. It was my decision. I thought that let us de-escalate. Why should I to put her on so many antibiotics? De-escalate to simple amoxiclav and metro. Okay, but that was the time she started having because she was settling very well. The pleural effusion was settling. Once the de-escalation occurred, again her left side pleural effusion started to increase. And in that period was that Klebsiella was caught, and that imipenem intermediate sensitive, and also we added amikacin. So these were a bunch of medications we had, antibiotics we had given, and a brief course. We received the patient with sepsis, and that was deep neck space infection. Within 48 hours, she had this pus drain, and with subsequent ICU care and with antibiotics, we could wean her off the mechanical ventilation. But since the left pleural effusion, I still didn't get it connected with something else. But with the left pleural effusion and septic embolization, why do I say septic embolization? Is because the right internal jugular vein, and that could have spread to the lungs, because emboli easily spreads to the lungs. So septic embolization, ICD was inserted to drain the pleural effusion, and we followed the antibiogram of this patient. Now, with these syndromes, then we did and literature search. This was the time we did a literature search, and very few patients have been reported on literature with this Lemierre's syndrome. Now, what is Lemierre's syndrome? It is nothing but an unidentified retropharyngeal abscess. It could be a dental issue, tonsillitis, pharyngitis, anything. There is an untreated retropharyngeal abscess which could go to the lateral space of the pharynx, gets into the internal jugular vein, both or unilateral, gets to the clogged up in lungs, septic emboli. That's Lemierre's syndrome. Lemierre's syndrome. A French physician identified this Lemierre's syndrome. So yes, oropharyngeal primary infection, pharyngitis, tonsillitis, dental, or sometimes viral infections as well. So the endotoxins induces platelet aggregation and septic thrombus formation, and the blood vasculature get affected, and thereby look at this, the lungs very common, and also the brain, CVT, cortical venous thrombosis, is very common. Luckily, this lady, when she had the emboli up to the sigmoid sinus, but it didn't go for a full blown cortical venous thrombosis, fortunately. So liver endocarditis and all other joints, these all can be affected by this septic emboli. Uh, so this font is not what I made, but it's different. The history of history of recent oropharyngeal, quick reversal. History of recent oropharyngeal infection, internal jugular vein thrombus, metastatic septic emboli is what I said. Isolation of usually Fusobacterium necrophora is the culprit, but also it can be because of Klebsiella, staph, or any organism. But if this structure is involved, think about Lemnius. And empirical antibiotic, we have to give patients at the earliest, otherwise this could be a young death occurring. So we have to be very careful in giving the antibiotic at the earliest, especially focusing the streptococcus, staphylococcus. For that, we can give Piptas, piperacillin tazobactam or ampicillin. We started her on Miro. And tailored therapy has to be thought about, but this should be continued for 3 to 6 weeks. I remember I said that I kind of de-escalated her antibiotics. The septic emboli started getting more into the lungs, and that's why her left side lungs had more pleural effusion. Now, there would be a question from you, or you'd be thinking, why did I not think about that this is a TB related pleural effusion before, and we have this immediately. We start on empirical ATT. We are very very careful in taking calling off for an empirical ATT because so many multi-drug resistant mycobacterial tuberculosis. Many are rifampicin resistant, and so much modified regimen is being given. If these things continue, then it's a difficulty. So now lately we are trying to strictly emphasize antibiogram of that particular hospital being followed. CMC Vellore is strictly following that, and so that should be something which we Lifeline Hospital is also strictly following, that not to be over treating, but also not missing the indication is what's the beauty of saving lives. So abscess drainage, yes, was done, but there is also the vascular surgery. People told me that this is an young lady and she's growing recurrent thrombi, and also I placed her on low molecular weight heparin for this thrombus and also acetylene. Acetylene we have to continue for 3 months, but there is a controversy. Some don't recommend that, but we were continuing for 3 months, monitoring her INR, PT-INR. So vein ligation and excision of the internal jugular vein can be indicated if the thrombus is throwing up severely. In her case, it was not, fortunately, thanks to nature. And now, see, the use of anticoagulation for Lemnius syndrome is controversial, like I said, but we can take a call. I gave her acetylene 2 mg, 6 p.m. And she still is on acetylene, fluid resuscitation, all other measures which we could carry. Now, this is the patient. How she was on, on the day of admission. This is 42nd day of admission. And this was our hallway to IMCU, the Rajiv Gandhi Government General Hospital. Okay, anyway, so it's not videos. Anyway, she was walking all the way. I just wanted to show you that, there was a great improvement in her clinical state. And she was telling that, I just asked her to walk and come, sir. She said, I'll run and come. That's what her happiness. So the take-home message, we all have to work as a team. Multidisciplinary role is teamwork, no replacement. Multidisciplinary approach to is vital. Lemier's syndrome, rare but serious complication because of oropharyngeal infection. Any young, otherwise healthy patient who has repeated unexplained symptoms after sore throat, think of Lemier's. Ensure that appropriate antibiotics are started after confirming if it is Lemier's. Please go minimum for 3 weeks. But in her 3 weeks didn't work, go for about 6 weeks. Just make sure that we don't we have to do routine cultures, and that was day 79. Uh, that was the time she was discharged. And her tracheostomy, everything was removed, and she was all right. A week back, I called her sister. She's doing reasonably okay. But then one other thing is, we having treated her completely. 90% she was okay, but still she had some remnants of loculated pleural effusion over her left. She was asked for decortication. Now, always remember, uh, you know, uh, before getting into an intervention, should we go for an intervention or should we wait? It's a clinical decision. That's an experienced thought, matured mind. So in her case, we didn't go for decortication because already she was very weak. Somehow we managed her to improve the nutrition. So now it is resolving, but we need, if the septations are there after 6 months, because one other thing is decortication in a case of such an a moderate loculated effusion. Uh, if the patient is a breastfeeding mother, you cannot go for a decortication for 6 months, because once decortication occurs, she wouldn't be able to feed the baby. So we are waiting, if at all, after 2 months, if it doesn't settle, then I might ask our cardiothoracic surgery team to take a decision. But yeah, as of now, she's good. Thank you.